Hello, my name is David Yarmand. I'm an oral and maxillofacial surgeon practicing in Toronto, Canada. My talk today is on current concepts in immediate implants. And before I begin, I'd like to take this opportunity to thank Dr. Solano for inviting me once again to speak to you. It's always a pleasure for me to speak to the dental XP community. So let me begin my talk. It's titled Current Concepts in Immediate Implants. And just to give you a preview, we're going to cover quite a bit. Generally, it's broken down into aesthetic zone implants and molar sites implants with some talk about temporization and other factors. So let's begin. So the benefits of immediate implants, obviously it's one procedure, one surgery, no need to go back in for a second surgery. Allows for temporization at the time of placement if so desired. And you can actually manipulate soft tissue during the healing component and for soft tissue stabilization. The question of cost, I don't particularly charge a lower price for an immediate implant. My fees are the same. Where the patient can end up saving on something like this is if they need to be sedated, for example, for the second aspect. If it was a face surgery, then they avoid a second sedation as far as that goes. But otherwise, the fees are, in my practice, almost identical between the two. So what about the factor of predictability? Are immediate implants predictable? And the question becomes, what is considered predictable in the sense to do an actual procedure? At what point is it becomes valid to do a procedure based on the predictability number? So 95% yes, most of us would be very comfortable with. 90% also would be a valuable thing to do, actually, a procedure. When you start getting into the 80% and 70 percentile, then it becomes a personal preference, and there's obviously specific situations at hand with patients and things like that that can alter these numbers a little bit. But again, it's a subjective question. There's no real right answer to this. So let me just discuss a little bit about the actual procedure part, and I'm not spending a lot of time on this. So here you see an alveolus with the tooth already extracted, and the inclination initially is palatal as far as the placement goes, not as exaggerated as what you see in this picture, because rarely do you have that bulk of a palatal bone to do this, like they're showing in here. But you prepare your osteotomy site, and then the implant is placed. And I'll draw your attention to the space between the implant and the actual buccal surface, the buccal bone. So the buccal surface of the implant and the buccal surface of the bone. And I'll get into quite a bit of detail as far as that goes and what needs to be done for that. So again, here's another graphical picture. You see the implant, you see that elliptoid representing the buccal bone, and we need that space between it. Never ever to touch the actual buccal wall when an implant is placed. And that in itself, if an implant is placed, not only does it have tubucally, not only does it have aesthetic compromises, but also there could be potentially compromises with the buccal wall resorbing. So what about survival rates in immediate implants? So obviously the comparison needs to be to conventional implants. So we know conventional implants been around a lot. There's been a lot of studies on them, various different things. Various different authors have looked at it. I just chose this one in particular, Jung et al. Study in 2008, the systematic review, 5 years at 96.8. And incidentally, you'll see all my references noted either below the fact that I'm stating or to the right of the screen. But we know that implants work. They last a while. Now, what about immediate implants? What kind of numbers do they have? Well, at 2 years, pretty good, 98.5%, and at 4 years, 97.5%. So this is one study, Lang et al. In 2012. So they do well comparatively. I think the numbers that you see in front of you, there's not enough of a difference to say that immediate implants are more successful, even though the numbers are higher, but we can safely say they're about the same as far as how they do. So, incidentally, no difference between posterior and anterior immediate implant survival, and no difference found also between the maxilla and the mandible. So what about soft tissue changes? What kind of effects do immediate implants have on that? Do we have any, is there any advantage to doing this? So some authors say that there is automatically more recession in immediate implants, and others say that there's actually no difference in recession between immediate and delayed implants. And finally, others say that there is less recession in immediate implants. versus conventional implants. Now, there's not obvious consensus on this, and it depends a lot on the clinician's hands and the studies that were conducted. So I think this is not quite established as far as there any clear benefit. It might actually make no difference. So let's talk a little bit about bundable, because you hear that word a lot, and I'm going to try to answer exactly what that is and why it's such an important component for implants. So what we see after extraction is resorption of the collagen-rich bundle bone. Now, there's always dimensional changes, and there's a lot of studies, again, that show this, but I'm just going to review one of them. Basically, the dimensional changes for this study that I chose, show that there's a decrease in width, about 4 millimeters, decrease in the soft tissue thickness of about 1.6 millimeters, and finally a crestal height difference of 1.5. And this was a 2009 study that conducted. Many of them have been put out, and the numbers are pretty similar among the bigger studies, but you can see that generally you take out a tooth, there's going to be dimensional bone loss. So what exactly is bundle bone? So in the diagram to your right, you'll see the bundle bone is actually alveolar bone proper. That's what it's labeled at. And it's a collagen-rich type of bone. So the question becomes, why does the buccal plate disappear when a tooth is extracted, and what is bundle bone? So bone with collagen fibers embedded from the PDL. That's what bundle bone is. So it belongs actually to the periodontium, to the periodontal structure. It really is part of the tooth also. So it's essential for bone preservation. The PDL is essential for that. So the blood supply for the buccal plate comes from 3 sources. And this is from the 2012 Dental XP Global Symposium that Dr. Tarnow presented. And the first source is the PDL. The second source is going to be the periosteum. And the third source is the underlying bone. So there's some of these factors that we have control over and some of them that we don't. So for example, the PDL is tooth dependent, and when the tooth is gone, the PDL is gone. The periosteum comes from the flap, and that's affected by whether we remove the flap from the surface bone or not. And then finally, the underlying bone. So one thing I'd like to speak about is actually what I like to use for extractions that I am concerned about the buccal bone fracturing off due to thinness or any other factors is the use of a piezo device. So there's times where even specialized elevators don't allow you to take out a tooth quite as atraumatically as you'd like this instance, for example. And I find that the use of a piezo helps quite a bit with this. So when I use a piezo, I actually use it in the interproximal spaces and not on the buccal space because it's not delicate enough. It can actually remove the buccal bone. And palatal if you choose, but I find it to be unnecessary most times. And then the tooth gets elevated out. So we spoke about the tooth as far as the PDL goes, then the periosteum and the flap. So the question becomes, does flapping make a difference or not? Is there an effect on the flap? So there's studies that show that flapless surgeries end up with less recession, and there's others that say that there's really no difference between a flap and creating no flap, with caveats, of course, as far as the surgical technique goes. So again, not fully, there's evidence on either side of this talk, both sides of the coin. So, generally, I personally feel that flapless does make a difference, that there is less instances of recession, and I'll even show a study, one of my cases that do emphasize that. And then finally, again, the underlying bone. So do immediate implants prevent bone loss? That's a definite no. There's no function in the implant itself that retains bone short term. So no PDL, no bone. And the tooth is what comes out, the PDL is what comes out with the tooth. So there's plenty of evidence with this, and it's pretty clear cut as far as that goes. I like to point out a study that I find interesting. This was by Uli Grunder back in 2006, I believe, in IJPRD. And what you see here is, the title of the paper is Influence of the 3D Bone to Implant Relationship on Aesthetics. And what he found was that as far as a single implant goes, the bone and papilla are dependent on the attachment to the adjacent teeth. And I think many of you who have placed a lot of implants intuitively know this. Where the papilla ends up, where the bone ends up, depends on the tooth next door. The deeper the implant, the greater the required tooth distance is. In other words, the further deep the implant is placed, the greater bone you'd like between the implant and the tooth. And that's required because the deeper the implant goes, then that's what's necessary. And I'll show that diagrammatically. So on your left, you see that triangle there, and for a shallower implant, on the right is a deeper implant. You can think of the top part of your screen as a platform of where the implant ends up. And the bottom, where the point is actually the interproximal bone. So if you just compare the two, you can see there's more bone volume on the left side than the right side. And the more bone volume, the greater the stability of the bone in the implant is. So this is what I inferred from this study, and this is, I think, why we need to keep greater distance from the implant and the tooth as we go further deeper with the actual implants. The other interesting note in the study was that the authors recommend to do a guided bone regeneration procedure if there's less than 2 millimeters on buccal bone, even if the threads are not exposed. And I think that most of us agree with that. So what about 2 implants? What affects the bone with 2 implants? So the bone and papilla at this point are dependent on the actual implant position, barring the other sides of the implants where the teeth are. So implant to implant connection now is dependent on the actual implant. There's no more periodontium and there's no more tooth. So now the number needs to be increased. You need a minimum of 3 millimeters in the implant distance, preferably 4. Nowadays you hear that you can push that with newer implants or platform switch implants. I'll address that a little bit later on. I think it's still always a good idea to be able to separate them by 3 millimeters if possible. And again, the same idea. The deeper the implants, the greater you need between the 2 implants. And finally, also, same recommendation of GBR required if there's less than 2 millimeters, even if the threads are not showing. So what about immediate implants in infected sites? So can implants be placed in infected sites? The short answer is yes, they can, but with caveats. So for the most part, not an issue. You can place them, and I'm going to review this study that you see on the bottom of your screen, the Kanovic in 2013. This was, again, a systematic review of implant placement, and they found that there's comparable success rates to non-infected sites compared to infected sites, which is pretty interesting. You would think that there's a concern that the infection can stay there and affect the implant and lead to periimplantitis, but according to this paper, it doesn't. But of course, that comes with caveats, and that means meticulous cleaning, and I put that in quotes because that's what the authors stated, but meticulous cleaning and debridement of the area, which is not always possible depending on the anatomy of the site and what's left. So what about pre-op antibiotics? Does that make a difference as far as success rate in infected implants go? Ends up, it's not quite clear if they have any difference or not. I personally do place my patients on pre-op antibiotics before placing an implant in an infected site, but the literature is mixed on that. What about antibiotic irrigation in the site? Again, also unclear. Evidence on both sides, whether it works or not, or doesn't work. So what about perioperative or preoperative Paradex? Ends up this does actually work and make a difference, a statistical difference between success and failure between implants. So in infected sites, specifically, that's what I'm addressing here. So I think it's pretty much common sense that Paradex should be used pre-op with implants because there's no real consequence on that we worry about things like antibiotic resistance and things like that. And there's really no harm with using Paradex, so I do use it with all my patients, whether they're infected or not. I do preoperative Paradex with patients getting implants. So I alluded to the gap earlier, and that's the gap between the implant and the buccal bone. So how do we manage this gap? So I'm going to ask a few questions during this talk, and we'll address each of them separately. But what's the minimum gap needed? Is grafting necessary in the gap? and what type of bone would be best in the gap site. And finally, does temporization make a difference? So I'm going to just preempt this and give the answers and then elaborate on each of these points throughout my talk. So the minimum gap is about 2 millimeters and probably a little bit more than that if is preferred. Is grafting necessary? Maybe. Literature is mixed on this. What type of bone? Not quite clear. There's no good consensus on what's best. Everyone has their preference. And what about temporization? Does that help? Again, maybe. We don't know if that makes any difference at all. So the minimum gap needed is 2 millimeters, and that's the space again between the implant surface and the buccal bone. So we find that there's higher incidence of recession with buccal positioning. This might be not even related to the gap distance, but just generally the buccal positioning creates an aesthetic compromise with this, and we end up losing more bone. But the question is the greater the gap, the better. Is 10 millimeters better if we were able to do it? Well, I think the answer to that is not necessarily, because first of all, we're limited by the palatal bone. You can't put it that far back. There's always going to be a certain distance we can't reach if we want. But I think the minimum is 2 millimeters. So definitely greater than that would be beneficial. Up to what point, I just don't know, and I don't think there's good consensus on that. So is grafting necessary in the area? It may be, and I'll actually show some studies that speak about grafting not being the required, because intuitively you would think that, yeah, it's a good idea to place grafting material in there. So I'll point you to this study again that shows that there's dimensional loss and changes when you take out a tooth and the numbers behind them. But these studies are based on flapping the surgical site. So what if you didn't flap anything? Would there still be those dimensional changes? And is grafting necessary in those instances in the flapless site? So let me point you to a study. This I think is a very interesting study, and this was done by Dr. Tarnow and Dr. Chu. It's a one-case study, but I think it has quite a bit of an impact for a one-case study. So what the authors did was they placed an implant in a canine spot, and there was a 4.2 millimeter gap distance between the implant and the buccal bone. There was no bone placed in the gap, just a healing cap. And this is the changes you see after about a week, and this is what you see after 9 weeks. So everything's closed over and everything looks healthy and okay. Now here's where this study becomes very interesting. They actually removed the implant from the patient. This is a person that they placed it in. So they got permission to be able to remove it and did histology on the implant and found no real changes in crestal bone with the implant. The implant bone was at the right spot up to the first thread. So even though it's one case study, I think this is very strong evidence that maybe it's not necessary to place grafting material in the buccal bone. I think we're still in the early phases, and I think there's no harm in placing bone in the buccal space. I personally do it myself also, and I'll get into that a little bit later. But I just find this very interesting as a contrarian study. So let me show you another study by, again, Dr. Ole Grunder. 24 cases. 24 patients overall, 12 of them had immediate implants placed, just immediate implants. No bone, no anything, just placing an immediate implant. The others had immediate implants placed with a connective tissue graft. Again, no bone in that group either. No flap, no bone in it either. And this is what the results were. So 6 months later, the dimensional changes were measured, and what you can see is that the soft tissue thickness of the group that had no intervention, in other words, just the implant placed, they lost about 1 millimeter of soft tissue thickness, which is actually pretty good in and of itself when you think about it. The group that got the connective tissue graft actually gained 0.3 millimeters, 0.34 millimeters exactly. So that's why there is a maybe behind this. There's, of course, other studies that show that grafting does make a difference. And I think that's the common clinical understanding and practice. But those two kind of are contrarian in the sense that they state that maybe there's no need for that. Are we ready yet to make that leap? I don't know. I'm not until I see more evidence. So what type of bone should be placed in the space between the buccal wall and the implant? And again, it's not clear. There's advocates of BioOss that say, or xenografts in general, that say they work great. And there's other opponents of xenografts that say it doesn't work great. So there's really no direct comparison that I could find that showed a difference between autogenous bone versus xenograft versus allograft. And that's the issue. That would be really the study to create to see if there is such a difference or not. But I couldn't find anything that addressed that itself. So what about temporization? Does that make a difference? Maybe. And I'll talk a little bit about temporization a little later on, but there's studies that show that it does reduce recession, and the idea is that it probably actually has to do with graft retention when the temporization, the temporary, is placed over the implant. And also there's evidence that there is soft tissue shaping, which clearly intuitively we can understand. So how do you make a temporary? So depending on the camp you speak to and depending on who does it, probably oral surgeons are the least group who make their own temporaries, but I'll discuss it a little bit here in detail. So first you need some kind of a matrix. The matrix can be a putty, it can be a vacuform. So a vacuform, for example, what you see here is over the models, and then there's a temporary abutment, and there's different temporary abutments. There's PEEK, there's stainless steel, there's a bunch of stuff. So and then the material is placed in there, and then you pick up the actual material. And I'll show a few cases of how that was done. There's also polycarbonate crowns, but the theme is basically you need a shell of some sort, something to hold the material that's going to go over the implant abutment, the temporary abutment. Here you see it filling in with whatever material you choose to use and placing it over the implant abutment. So this is a study in 2012 by Dr. Chu and his group, and along with Dr. Slama and his group and Team Atlanta. And I think it's a great step-by-step study as far as showing what the steps are to create ideal temporaries. So I'll go over it and I'll review it and I'll discuss it in detail a little bit more. So what you see here is the implant placed in the correct position, palatally with a gap distance in the front of it. And then a PEEK abutment is actually placed over it and adjusted, not fully cut off, but adjusted enough where a shell, which is prefabricated, usually in a putty matrix, actually with jet and powder and liquid, and then placed over the actual temporary abutment. So now the temporary shell, the shell and the temporary abutment are adhesed to each other. The whole thing is removed because this is a screw retained structure and it will stay that way. The voids are filled in, and there's obviously different materials that can be used for this. I don't use powder and liquid. I use a flowable composite to fill in the voids. Or other temp materials. But once this is removed, the critical thing is to actually point out the contact points and mark them, because you don't want to actually go in there and start trimming the contact points. So the voids are filled with whatever material you choose. Everything is cleaned up and polished. And then prior to placing any bone and any structures in the implant, you actually complete the temporary fully. So the temporary is actually created before anything is placed in the socket except for the implant, for the final position of the implant. Then bone is packed into the implant. It doesn't have to be packed with tremendous force. You just place it into the actual socket space. And the key thing in this, and the interesting point is that bone is actually packed coronal to the bone level. So you actually place bone to the gingival margin, all the way up as high as you can go. So here you see where it is. It's actually at the gingival margin, not at the crestal margin, and just plump up that area. And then the temporary is placed on, and as it squeezes down, excess grafting material extrudes out of the site, and it's just passively removed from the area. Nothing too aggressive, nothing moving too much. And then the temporary, again, this is screw retained. The temporary is tightened in, and the hole is filled over. So I'm going to discuss the aesthetic zone a little bit more in detail, because this is the area that's more involved with temporaries and what we do in here. So this is a very interesting study that was actually done by Dr. Chu and his group, and I wasn't able to, I heard about it at the Dental XP Symposium last year, and I wasn't able to find the study online, and I contacted Dr. Chu, and he was kind enough to provide me the details and information on this study, so thank you, Dr. Chu, for that. So I'll try to review what I spoke to him about, and hopefully that study will be published very soon for everyone to see. So the big question here becomes, when does bone volume loss become noticeable? Because at the end of the day, that's really what we care about. Does anyone really care if a 50-foot tooth is placed on a 100-foot screen and if it doesn't look quite right? Would anyone ever notice that clinically or in real life? And of course not. Nobody would. It doesn't matter what it looks like on a giant screen. The question is, does it look noticeable on a person? So the way this study was conducted, there was actually 100 online respondents that compared a central implant versus a central tooth. And the idea was, there was buccolingual bone loss measured, and the idea was, which one of these is noticeable that there's an implant in there and there's bone loss? So the question that was asked was, do you notice a change in soft tissue color? There's more to this study than I'm describing. There's delta values and other factors that is beyond the scope of this talk. But basically, that's the gist of it. To ask, do you notice a change in soft tissue color? So here's the graph that I just adapted from Dr. Chu's presentation that he sent to me. So basically what you see here, the bottom values are the degree of bone loss that was assessed buccolingually, and the other axis, you see the respondents answering to the question. So with low levels of bone loss, from 0 to 0.5, most of the respondents said that they don't notice any kind of soft tissue change. When the numbers increased in dimension, when there was greater bone loss in the area, that's when there was actually noticed that there was greater soft tissue changes in tissue color. And the reverse of that is of course the same, where the vast majority of people in the 0 to 1 millimeter, below a millimeter, noticed that there was actually some changes in the soft tissue color. So very few answered yes with low bone loss, and very many people answered yes with greater bone loss, and the vice versa with the no answers. So 75% of the answers were actually in this category of the 0 to 0.5, with the remainder being on the right side of the graph. So it kind of implies that you need to stay below a millimeter of buccolingual bone loss to avoid soft tissue color changes. There's other factors, and that's the key important take-home message here, I think. It's not just about bone dimension. Tissue quality makes a difference. I'll show a case that I did that addresses that, and the native tissue color and other factors like that. So this is not everything, but I think it's a good start as far as assessing what really matters to patients. So let's talk about a few things more in the aesthetic zone. So what I'm showing here is basically 3 smile lines, and you can see on your left is the low, the medium, and then on your right is the high smile line. And obviously these have very, very vastly clinical demands as far as how these are managed and how they're treated. So how do you manage these different kinds of cases and what's addressed? So I'm going to point to a frequently quoted study. This is actually a very interesting study that talks about the dimensional changes in the socket wall in a population. And the way they measured these was actually they flapped the area and they measured it with a caliper to see how much bone there was in existing patients. So they had 93 patients, 93 extractions from premolar to premolar, second pre to second pre. They measured the buccal wall thickness. 90% of this group had a facial wall thickness of less than 1 millimeter. So think about what that implies for a second. 90% had less than a millimeter of bone on their buccal face, and 93 patients is a significant number. So here's a graphical representation, so let's look at that a little more closely. So this was their breakdown of dimension of the buccal wall. So 64% had 0.5 or less. 23% had one between 0.5 and 1. And then this compromises 87.2%. That's the 90% I was referring to that I rounded up. And then the remaining were 1.5 and 2 millimeters. So look how few people had thicker bone dimensions. This would be anything about 1.5 to 2 millimeters. So you can imagine the clinical implications of that. Every time you flap something, no matter what the studies show, that when it's a whisper-thin buccal bone, there will be buccal bone loss, without a doubt. So that I thought was a very interesting factor. And again, draw your attention to this once again. This is the buccal bone changes with the bundle bone as far as extractions go. So the idea of this, the reason I showed this slide was I wanted to review an article here that a technique called the socket shield technique. This is not something I have any personal experience with. I've actually never done it before. But this group, which was, I believe, originally the paper a few years back was by Dr. Hertzeller, was actually the original one with this. So I'll describe it a little bit, and then I'll get into the reasons why I don't particularly like this kind of a technique. So this study was a dog study, and what they were trying to show in here was that the initial study was showing that if you leave a fragment of tooth, a buccal shield, so to speak, that it will result in less buccal bone thickness and implant survivability won't be affected by that. This one here is kind of the next step where they talk about, okay, what if there's a vertical fracture? Is that going to affect things? Does that make the socket shield technique still viable? And the answer, spoiler alert, yes, it makes no difference. It's fine. So here's the idea behind this technique. You remove all but the buccal surface of the tooth. So in other words, you keep a buccal sliver of tooth still attached to the bone. And the idea is that, well, you're not violating the buccal wall, therefore the tooth stays. There should be no bone loss. So what they did in the Beagle study is they also created a notch to represent the vertical dimensions. And they did histology and found that, yes, buccal bone was retained because the tooth was still there. So it goes back to the PDL bone relationship, while the PDL was never removed because the tooth was actually kept in there. And the histology is quite impressive. There's bone there and there's no issues. They actually also show a case study in a person. And you can see the preparation site there. Place the implant, and then it's loaded, and there's not an issue. So I can't really speak to this technique. I can just imagine what the issues would be with this. This sounds complicated. It sounds to me difficult and long procedurally to actually do this technique. In other words, you have to remove most of the tooth, but not all of it. I can't imagine implant drills going through a tooth, so you have to use high-speed instruments to remove it properly. It just sounds like a lot of fuss for nothing, and since most of our current techniques are fairly reliable also, but for those who want to experiment with this technique, the paper's there as far as seeing how it's done. I personally will not be doing this technique. So how do we evaluate for immediate implants? What do we have to think about when we're doing this? So obviously we look at pre-surgical diagnosis. These are things like smile line, tissue quality, and things like that. We care about an atraumatic extraction to maintain as much bone as possible. And then we have to also worry about soft tissue management. So these are the factors that we have to think about when we do this. So a little bit about pre-surgical diagnosis. I'd just like to draw your attention. This is from the ITI 2009 SAC classification. It's not exactly that, I altered it, but what you can see on the left column is the different factors and the low and high risk. So when you go from the left to the right, it increases the complexity and difficulty of the case. So things like smile line. A high smile line is harder to treat than a low smile line. thick is harder than, thin gingiva is harder than a thick tissue quality, scalloped, flat. You can see all the way. And finally, aesthetic expectation, which probably to me is the most important, low versus high. So most of you know this, that place immediate implants in the aesthetic zone. These are important factors that need to be considered. And it might alter the way you proceed with the treatment, that in such instances where too many factors are weighted on the right side of this graph, that maybe it should be phased. Maybe it needs to be site preserved and then come back later to actually place the implants. Certain things go together. They're generally not independent of each other, such as biotype, architecture, and tooth shape. And finally, for me, the most important thing is I'm aware of a patient with very high aesthetic expectations. We've all had those patients that demand more than they want, and they can actually have nothing to do with the factors above this line. In other words, your patient can have a low smile line, great tissue, a ton of bone, everything's perfect, but they will be the one that is going to pull their lip back and notice that there's a 0.5 millimeter difference between the left and the right central. So we don't always know those patients who they are going in, but at the end of the day, that's going to probably be the most relevant factor to do these kind of things. So I just wanted to show this chart as far as relative contraindication. This is from a textbook Dr. Fugasato wrote in 2007. There's a lot of factors here. You know, obviously, the more the factors, the more it becomes almost a absolute contraindication. But I have violated many of these, and again, depending on case selection, I don't think there's a good recipe as far as, okay, which ones are contraindicated versus not contraindicated. But this will give you an idea in line with the previous chart you saw as far as difficulty goes and what's involved. So what about platform switching? We didn't always have platform switch implants. So does that actually make a difference? So let me just explain what platform switching is. So the idea is that a platform switched implant actually moves the junction between the abutment and the implant away from the crestal bone. It's similar to a biological width description where all the bad things happen in the junction between the implant and the abutment. So any toxins or any kind of bacterial factors or toxins end up destroying the bone should be moved away from it. There's the argument also that it adds to the biological width with increased tissue and increased connective tissue mass. So here's another representation. This is just another company's shot. So what you can see, the area that matters is that circle there, and this is how I would describe it when it's blown up. You can see the tissue and the crestal bone, and the idea is move everything away from the crestal bone as much as possible, so it moves away from the junction. So I'm going to show you a case where the fact that maybe the presence of an implant, platform switch implant, is what made a difference or not. This is a case I did many, many years ago. I saw this patient about 8 years ago. This was not an immediate implant case. This was congenitally missing laterals. I placed a platform switch implant, and then it was restored. And I was a little concerned about just kind of, there's a dark hue around the initial crown placement, and I was worried there was going to be recession over time. And then I saw him, he was gone for many years, and I saw him about 2 years ago, after about 5-6 years of the implants being placed, and the tissue is completely stable. It actually looks like it's even gotten thicker. Nothing else has been changed. Those crowns are the same, everything's the same. So whether the platform switched implants contributed to this or not, I don't know, but I would say that probably that's made a difference as far as the outcome goes. Now, a little bit more about the aesthetic zone. I'm going to show you a case. I'm going to go through the cases now as far as case presentations and show you the different types of cases that I've done. So here's a patient, fractured tooth, not really high aesthetic expectations. You know, my favorite kind of patient. They don't care. They just want a tooth there. He had a flipper already. I personally hate flippers, but he had one, so there was no issue there. So this was going to be an immediate implant. You can see everything is easy. Tissue's great. There's no issues. There's bone there at the time of extraction. And we have a perfect ideal scenario. This is just showing where the crestal bone is, about 3 millimeters apical to the soft tissue margin. So the implant's placed. I put bone in the gap between it, just place a cover screw and place a collar plug over top of that and suture it in, and almost like a site preservation. This can be done just as easily with a healing cap. There's no real reason to bury this. I don't think it's necessarily more successful with when it's buried under a collagen plug, but it might be. And here's the post-op Panorex. This is him immediately post-op, and that's his smile line. And you can see that it makes no difference, and the tooth looks ideal in his eyes, and he doesn't really care. So here's another case. This is I found this to be a little bit more interesting as a case after I reviewed my previous cases. So this was again another immediate implant, a lateral position that's failing. I personally find laterals more complicated and more difficult to manage because the extraction, the alveolus is always smaller. Even though you can use a smaller platform implant in the site, the alveolus seems to be smaller than what's matching with the actual implant size. So I'm always a little weary of doing laterals. I tend to scan, I tend to do a cone beam scan in most of my aesthetic zone patients, but I'm especially wary of lateral positions. So again, the implant's in, pack some bone in the space between it. This one you can see I placed a healing cap over top of it, a short one, closed over. And here he is at the time of the crown placement. You can see on your left. Tissue looks pretty thick. It looks pretty good. And then he has his crown. This picture is about a year later after his crown's been settled. And this is about 2 years later. You can see actually it looks like it's caving in a little compared to the edge of the picture on your left. And here he is 5 years later. It's changing. There's no doubt that the area is collapsing, and it's the tissue quality is changing and the color is changing a little bit. Now, it's been a while. It's not like this was a month later, but there is definitely some dimensional changes, even though all the steps that I traditionally do and were followed. But still, even with everything done the regular way, you can see that there is still a little bit dimensional changes. Will this make a difference long term? Yeah, probably not. It's probably going to stay fine, and patient again doesn't have high aesthetic demands, so he's happy with it, and that's really the only thing that matters. But I just found it interesting as a point with documenting my cases that I started to see this. I didn't think I would. So here's a little bit more of an elaborate case. This is a temporization case that I'll show you, and I'll show you a second temporization case that's a little bit different than this. So this patient had, what you're seeing here is the central on your right, the 1-1 in international numbers, and the 2-1 is a Pontic. So the 1-1 is a natural tooth, the 2-1 is a Pontic space. There's no tooth underneath that. So here's his cone beam CT scan. We were debating how to treat this. That's why you see a lot of the images is rendered in different masks for the teeth color. So we were considering maybe doing 2 implants in the lateral with a 4-unit bridge, and there was a bunch of options on hand to do this because you'll see on the next shot, the centrals were very far extruded. They were in a terrible aesthetic position. And what you see there are the virtual implants that are placed in there. And then we tried with virtual teeth, just erase the teeth that were existing and place virtual teeth in there. And that you can see, that's aesthetically acceptable. That looks pretty good aesthetically on the cast. And if you look at the difference, right there is the edge of the virtual teeth that is poking out, and the existing teeth are protruding beyond that. So quite a bit of a difference from what we were planning to do, where we were planning to place his teeth versus where his teeth were now. So let's show the surgery. So here he is pre-op. You can see, again, his smile line is low. He's higher in animated smile line, but still, he just shows his lateral. And by the way, when you're testing for this, a lot of times you'll see that the only time I see a natural animated smile line is when it's natural, when the patient is laughing. Even when I ask them to exaggerate on my typical typical script is laugh, give me a big fake laugh, smile like you're in front of a camera. But still, you notice more, the facial muscles are much more animated when they're naturally laughing. So he's actually more aesthetically, his lip line is higher than this, but you can see it's not dramatic. It's not, he doesn't have a very gummy smile. So here he is at the time of surgery. So the right central was extracted. The left pontic space is what you see there. And you can see the projection, the buccal palatal width of the socket compared to the pontic site. See how much collapse there is since that central was taken out many years ago. There's a ton of bone collapse there. I like to use just a straight old school vacuform Essex to see where my tooth positioning is going to be. This is based on the wax up he had done by the lab. Just as regular suck down vacuform. Sometimes I'll do guided surgery with guides and other things like that, but a lot of times I find that this is enough. This just tells me where they should be going. The implants should be going. It just visually gives me a much better idea. I feel like I'm in a lot more control when I use these versus guide or even the guides that labs make, which I never use. So here you can see the pontic space ridge. And it was too thin, so I did a ridge split, and the ridge splits and the vertical cut is what you see on the patient's left, your right. Expanded that site and placed the implants. So look at the difference in gap between the implants, the right central and the patient's left central. Well, obviously the left doesn't have a gap because there's not a socket there, but it's a big difference in bone. I was trying to retain the flap you see on the patient's right side. I didn't want to do anything too extensive to just flap everything like crazy, but I had trouble because these are just the temporary abutments that I'll show you that needed to be trimmed. And incidentally, when you place these temporary abutments, they always need to have the cotton balls placed in there when you're building temporary over it. But as far as the implants go, I checked the stability to see if they can actually withstand temporization. Again, the patient has to be completely compliant, and my next case I will discuss why that was an issue, because the patient wasn't. The patient has to be compliant with not putting any force or load on those teeth, and also be compliant with their follow-ups and things like that, because this kind of surgery is much more involved. It needs closer monitoring. So I checked the stability to see if it can handle the load, and both those implants tested around 68 for the Austell device. That's an Austell peg, what you see. Trim down the temps and place the cotton ball in it. Always place the cotton ball, because in case you forget, it can become disastrous. The shell was made from just flowable acrylic and placed in a putty and placed over it. So I didn't use what you saw earlier, the Essex retainer, as my matrix. I actually used something different because you get better embrasure creation when you use putty versus an Essex. An Essex seems to be a little, the contours are not quite as nice, even though you can see a little bit more and see a little bit better. So that shell was placed over, the whole thing was picked up. We added, I used flowable composite for the spaces and increased acrylic over the voids and left the margins intact like I showed you in the previous slides. Placed it over. It's a little bulky, so it was trimmed a little bit more and polished a little bit more. So I took it off, and this is now I'm going to actually do the GBR portion of this. So you can see the implant threads showing in that buccal undercut of the left central. So just my typical GBR formula, what I do is I just put some autogenous shavings, then use allograft of choice, and then membranes. I might use xenograft sometimes over this, and then a membrane. I like to tack my membranes. I just found that when the membranes are not tacked, the bone that's created is not as robust. I feel that when the membrane micro moves, that it can create issues with that. So I personally like to tack my membranes when I can to stabilize them. I find it makes a difference. Again, anecdotal, but that's what I found. So you're looking now at the other one, the other tooth. There is a perforation also in that one. So it needed a GBR. I finally gave up on trying to make this minimal flapping, and I just flapped the whole thing and did a GBR on top of it with allograft material and also a membrane. So here's the occlusal shot. You see where the membrane, where the implants are placed with the membranes on top of them. I also did a connective tissue graft, just harvested. This is a quick procedure. I like to do these frequently because I think there's a big benefit to this, and it's not necessarily a it's not a painstaking, time-consuming procedure. So there you see the connective tissue graft, and I'm just attaching it to the overlying flap and just positioning it in a way that I want most of it to be underneath the graft with maybe a little exposure of the connective tissue rim. Many of you are more familiar with this than I am. So there you see everything is brought down, it's coronally positioned, and everything is tightened. There you see the access holes that are going to be filled with, I use flowable composite, but again, critical, don't forget to put the cotton ball in there and then just seal it up. Always a screw. I've never used a cement retained temporary. I've never used it that I've only used screw retained. So here he is a week out. Tissue looks nice. Everything looks okay. Here he is about 3 weeks out. And you can see the projection is pretty robust. His buccal lingual projection looks really good. He's still in the temporization phase, so he's not gone to final yet. It's been a while. So it's just patient was happy with his temps, so it was taking too long to actually get his finals on, which commonly happens, by the way. So everything is stable, everything is okay, and he's going to have a fantastic aesthetic result. And he was a very compromised case, so you can imagine that if you can remember what he looked like before, it's quite an improvement. I wanted to show this case because this is a similar case, but this case didn't go quite as smoothly. I had some issues that I came across with this one. And the vast majority of my problems were actually due to patient compliance. This is a young girl, very pretty girl. We went over a bunch of plans and basically decided those 2 teeth were not viable. So we were going to extract the 2 teeth and place immediate implants in those sites and temporize them immediately. So I'll show step by step where everything turned out okay, but there was things I would have done a little differently if I had the chance. So here she is pre-op. She's about 21 years old. And here is the cone beam with the virtual implants placed in it. So what you see on the right, the implant label number 2, which would be for the 2-1 position 2, it's getting close to that buccal undercut, but I felt like I could expand it easily and push that buccal undercut out of it without having to flap things and do a GBR. And it did work out quite well. So I personally do it tooth by, I did the first tooth without, and the reason I keep the other tooth in place is because I wanted to have my anatomy in place so I don't get too lost and too confused. So I did one tooth, then I did the other one, and now we're at the phase where we would do the temporary prior to placing the bone graft in there. So that's the implant platforms you can see. I placed the cover screw on them, packed it with bone, and prior to that we made the temporaries, and this was the issue that I had with this. I was out of those PEEK abutments. I had to use stainless steel abutments, and I don't personally like using these. They're more difficult to manage. They're, not a huge technical difference, but they're a little more difficult to adjust and adapt. The other issue I had was that I actually had to use a suck down vacuum form for this component, for my matrix. I find I get a lot less detail when I use a suck down instead of a putty matrix. So that was the other part that made things a little bit more complicated and made my temporary not as nice. The aesthetics were not as great. So missing an embrasure, you can see it's just not pretty. It doesn't look that nice. So placed it. I had to do a lot of adjusting, and that's why it's not that polished. This patient literally disappears for about 4 or 5 months. And we called her a million times to come in, but she was very non-compliant. Finally I get to see her. Finally it's a you need to come in, otherwise everything's going to blow up kind of situation, what I told her. And luckily everything was okay. But when I first saw that little dimple there, I panicked. I thought for sure that implant had failed. Ends up it was just a little piece of bone extruding. It was no big deal because when I removed the temps, I could see it from the inside and it was just originating in the tissue. It was not coming from anything else. But what's interesting in this picture on your right, I think, when you compare it to the pre-op, you can see there's buccolingual collapse and a significant amount of buccolingual collapse, even though all the steps were followed. So the implants were placed, the temp was made, the area was packed, and then the temporaries were placed on top of it. Everything was followed properly. There was no issue, but still there's a little bit of, not just a little bit, quite a significant amount of buccolingual collapse. And I'm not sure why. I don't have an answer as to why that happens. Maybe it just happens in some people and that's the way it is. But again, this was a surprise for me. I was not expecting to see that much. It doesn't have an aesthetic effect. Her tissue is great. Everything's okay. She certainly doesn't care. She lost buccolingual, buccopalatal dimension. But I find it notable and I find it interesting from a clinical perspective to see something like this when I wasn't expecting it. So that's this case that I found. Now her finals were, again, the restorative dentist actually was not that happy with the finals. She wanted to change them and make them prettier. Patient would have none of that. And she was just fine with it, which again speaks to what patients want versus what we want when we come to this situation. So aesthetically acceptable. It could have been nicer. She didn't want it, but nobody would ever notice this. No person would ever notice this as being an issue. And there she is. It's 6 months out, and I can guarantee you she will never come to me again for any pictures since she barely came to me for her post-op. So, and that's her post-op panoramics. So again, this was another one of those 2 implant cases. I know it seems like all I do is 2 implant temporaries, but I just wanted to show those 2 particular cases because I thought they were more interesting. So here's a case, not necessarily a temporization case. This is more of the plan was going to go down that road, and then we realized that it's probably not a good idea to do this. And this was what she came in, and her left central was compromised and needed to be extracted. So the big debate was, how do we end restoring this person? Are we going to bring her back to her normal gingival zenith heights? Because right now her laterals are more apical than her centrals, which is not right. It should be the other way around. Or do we leave it the way it is and just restore it to where it is? So we decided, the restorative dentist and I, decided to try to keep things the way they are without messing around things too much and trying to fix it for later. And she has, as you can see, a very high smile line. So I extracted the tooth, and she was scanned previously, and I wasn't expecting this degree of bone loss. You can see the tip of the Minnesota retractor going into that defect. Now, this must have happened from the time of her scan to the time I saw her because it wasn't there originally on the scan. So now we're looking at something a lot more extensive than just a simple immediate implant placement. So you can see the size of the defect. That buccal wall is thin and there's a crack there. I do the wrap, which is a regional accelerated phenomenon around the area there to allow the vasculature to get into the grafting site. I like to use PRGF for more extensive cases. It's not a miracle product, but I find that it helps, especially with soft tissue adaptation, and to use a fibromembrane with that. So here you see a tenting screw. This is a wide head tenting screw, and I place it at the apex, and there you can see the projection from the occlusal view, and you can see that bone got lost. That little crestal sliver got lost. Pack it with bone, mixed with growth factors. Place a fibromembrane over it, and then a collagen membrane over it. I don't find the fibromembrane, I don't trust it to be robust enough to prevent soft tissue involution into the graft. So I put a collagen membrane also, and then if I can, I actually put another fibromembrane over the collagen membrane. So here we are after healing, after about 4 or 5 months. You can see pretty good projection. It works pretty well, actually. And there's a screw, but not right at the crest, which is always the case with these kind of guided bone regeneration. Looks always better from the top than the crest. So here's the uncovery, remove the screw, place the implant, and I'm going to do an additional guided bone regeneration on that. I think that kind of a defect is conducive to a successful GBR, but it's going to be buried. I'm not going to expose this implant. Again, the same sandwich I like to use. This is with autogenous bone followed by allograft or xenograft or whatever. And then a collagen membrane placed on top of it. The whole thing is sutured down. And there she is with her temporary. We let that heal a bit before temporizing it, about 2 months before temporizing it. I don't like to temporize and do a very big GBR. I know you saw it in the previous case that I did, but generally when it's very infected and very dirty, I tend to like to close things up. And you can see already with the patient's right central that she's starting to lose tissue. It's going back on its own. And we all experience this, which doesn't bode well with the whole flap doesn't make a difference argument. But you can see it's starting to retract away from the margin of her other crown. So here's her final restoration. And I think aesthetically it looks fine. It matches her other previous final restoration, which is what we want. But look where we started. Look at the gap between the zenith of the laterals and the zenith of the centrals. And look where we ended up. Big difference between the two. And this was not intentional. It just kind of developed that way. So everything worked out fine and she's happy with the outcome. What I worry very much about is what's going to happen when that right central fails. And it will. And when that right central fails, it's going to be, again, going back to Dr. Grunda's study, it's going to be very difficult the margin is not going to end up where the tooth margin is. We have an implant next door now. It's not a tooth retaining the actual bone in between the intercrestal bones. So that's going to be difficult, and I got a feeling we're going to end up with a much longer crown on that, and then we're going to have to adapt the other crown that was previously placed on the implant. So hopefully she can keep it as long as she can, but it doesn't look too promising. So what do you do if you're not temporizing? Because not everybody likes to temporize. It's not easy. It's chair time. We obviously don't charge as much for the temporization as a surgical procedure for us surgeons. I charge a lot more for what I do surgically than I do for a chairside temp. So one option is to place an immediate implant, send him off to the dentist, and then makes the temp and adds bone, him or herself. That's one technique. The other way to do it is you place the immediate implant and then you place bone in there, but not all the way up. You can't pack it up like what I showed you previously. So then the dentist still makes the temp and just kind of tops off the bone and screws in the temp over top of that. Very reasonable. Another way, you place a healing cap and temp later on. Let it heal, let it do its thing, and temp later on. So few issues with this though. Number one, the patient doesn't leave with a tooth, but usually they like to. And the other issue is this. Many of you have seen this before. There's a stability dip at around 3 to 4 weeks where the implant is much weaker than it first went in. So that happens because primary stability starts to decrease and secondary stability starts to increase, but at that point they're at their lowest. So it's probably not a good idea to mess around with an implant at the 3 to 4 weeks. So I would say that realistically, it should be done maybe a week or two later. Even that's pushing it, or wait till there's better stability at the 6 or 7 week, and might as well wait till late at that point. So this is the big issue with doing things delayed as far as temporization goes. And then finally, the dentist can come to your office to temporize it. So they make the temp, and then you go in there, place the bone, and then the temp is actually placed over top of the bone. So I have referrals that do this. They come to my office, they build the temp, and then we work together to actually place it over top. So that's a common thing I do at my practice also. Of course, it also obviously requires a pretty good dedication by the dentist to come to your office to do that. And then finally, you do it yourself. So, and that is what I do a lot of the times. So I'm going to switch gears now and talk about different topic altogether, immediate molar implants. Again, this is not a procedural how to place an immediate molar implant kind of talk. It's more along the lines of, some pearls and tricks and things like that, and when not to do one and when to do one. So here's a study, a 2010 study. You see the reference on your right. It was a systematic review of immediate molar implants in meta-analysis. So basically what they reviewed 67 papers, only included 9, like is often the case with systematic reviews. They found that the survival rates in immediate sockets compared to survival are comparable to survival in healed sockets. So immediate implants, molar, this is a molar talk again, this is a molar paper, but comparable survival rates between the two. But there's no controlled studies. The literature lacks, and the authors address this. There's really no good controlled studies between immediate and delayed implants in the molar sites. I think personally that immediate molars are technically more difficult to do because what you worry about is a lot of burr chattering, and it needs a lot more stability to do it. And it's just technically more difficult than a single socket immediate implant, which I'm sure you can appreciate intuitively. It makes sense that that's the case. So let me go over a case. Here's a patient had a failing 4-6, first molar there. The extraction was atraumatic. The bone is intact. You can see the sockets. So the initial preparation, what I personally do is I actually just I just take a rongeur and I take out some of that septum. There's other techniques. You can place it in actually one of the socket holes. An implant can be placed there and you just angle it so it's a little more centered. I like to prepare it in the center. And I'll discuss it on the upper arch also. But you can see with the medium molars, the bone is tough. The bone on the septum is tough. So I just clip it off with a rongeur, not the whole thing, just basically less than the width of my implant. So I clip it with a rongeur, start drilling. I use 2 fingers when I'm doing this, and sometimes it's tricky, but I use actually 2 fingers to hold the head of the drill. And so I'm able to get as much stability as possible. And you need sharp drills for this. So you go into your rongeured hole and just try to keep it stable and increase like a regular implant. And then under prep, obviously. That way the stability is much higher. And I place it below the point of the crest of where it would be. Measured across, I don't like to put it... It's a little deceptive when you're doing these because you look like you're very deep, but you're actually not. Visually, it gives you the illusion that you're deep, but when you measure it, it's not actually as deep as it looks. So here you can use, I'm just checking the stability with an Austell device. Not that I'm immediately loading this. I would never load immediately a molar with a temp. There's no point in doing that. I don't know why some people would. It doesn't make sense to me. Just first, initially, I place a cover screw when I'm doing the bone packing part, because I don't want anything obviously getting into the implant. I pack it with bone. And then I place a cover screw over top of it. I place a healing cap over top of it and suture it up. And what you see in this case, what I ended up doing was that I thought it would just, the tissue would recede a little bit, but it didn't. It actually stayed up there. I just assumed it would pull back. It didn't, which is fine. Easy enough to trim, no big deal. So here you see the immediate post-op, panel. And you can see that with the periapical lucency there initially from the bat tube. Also in this picture is the PA. And this is after healing. Everything seems to be consolidating very nice. I'm happy with the position. It's in the right spot. It's where I want it to be. And then there's the final restoration. And it's a screw retain restoration, what you see there. And you can see again, it's not difficult to necessarily get it in the right spot. It just, It takes a little bit of experience and technique for that, but you can see it's right in the middle. It's basically in the central groove, the area where we want it. And there's the final PA. Crest of the bone intact. This is about a year later. Everything's stable. So I'll show you another case. This is an upper case. And this one was actually a little bit more complicated the way it panned out. So there was a compromised premolar, number 1.5. And later on, the 1.6 failed. So initially, I just took out the 1.5. And I didn't do an immediate implant in the 1.5. So why didn't I do an immediate implant in the 1.5? That's the easiest tooth to do an immediate implant, is premolars. The reason I didn't do it was that I wanted to site preserve, because between the premolar and the other premolar, there's actually bone loss there from the crown margin and from the root fracture, most likely. So I was just going to site preserve. I didn't want to put an immediate implant with that gap between those two teeth there with no bone in there. So I just let it sit, and then during the healing phase for the premolar, the other one failed. So we had to, then I decided the other one for the molar that I was actually going to do an immediate implant. So a little counterintuitive that I would not do an immediate premolar, but I would choose to do an immediate molar, but you'll see why. So here's at the time of the molar surgery. You can see the premolar site is healing. It's about probably 2 months out. I extract the molar, everything's intact, there's no buccal blowout, everything's fine. So I don't use a rongeur for the top, I actually use a drill for the top because the bone is so much softer and easier to manipulate. And I use, so what you see here is I placed the implant, the phased implant, in the second premolar site, and then drilled my molar site. And I love using osteotomes, and I use tapered osteotomes for this. Unlike other procedures with a sinus tap or core implosion, I use a straight one. But for these kind of procedures, I use a tapered osteotome. And I just do it by hand. I don't tap it, I just do it kind of manipulated by hand. Make the first drill and then expand after that, to give me primary retention, to make the bone nice and dense. So here you see the prep, the opening. There you see the implant. I like where it is. I'm happy it's in the middle. Everything's good. Now look at the buccal wall. There's a little crack developing, and here's where using an osteotome becomes a little risky, because I fractured it when I was using an osteotome. I might have avoided this if I was a little more passive using drills only. You can do this. You can be just as effective by underpreparing the implant site than as using osteotomes. But for me, I like using those. But this is what can happen. You can break the buccal wall, and there was plenty of buccal wall, so it was no reason for this to happen, but it did. Now I decided I was going to just do a guided bone regeneration. This thing is very far in. It's anatomically, the defect is good for building with a GBR. So again, same thing, autogenous, and then allograft over top of it, and then a membrane. And I decided I'm just going to bury it. I didn't want to do it. There's too much going on. I just decided I'm just going to bury it. So close it up, and there you see the implants immediately post-op. And here's the crowns after everything was restored and everything was finished. So good buccal width, everything looks healthy. There's no recession along the margin. Everything looks nice. And this is her when her crowns are on. And this is her about 2 years later. So total stability. Incidentally, you see, I actually leave my tacks in. If I don't have to dig too far to get them, I'll get them. But generally, I don't have an issue with leaving a tack in there. So that's the tack that you saw. So she's stable. Everything is okay. And this is her 2 year later pictures. So I'm going to discuss a little bit about very wide platform implants. I don't have experience with this. I've never placed one, and I don't usually use them. Many of my colleagues use them and are happy with the results and are happy with the outcome. These are not my clinical pictures. A colleague of mine sent these to me. So the reason I don't use this is because I don't think it's necessary to use this. If I can do the same thing with traditional implants that are established, that have been around for God knows how long, then I'll do it with a regular implant. If it just needs a little more, surgical technique, then I can do it with a regular implant, and there's really no need necessarily for this product. So what I worry about with this product, and it's just my feelings on this, is that I worry if this fails, it's going to blow up the whole area. Like, there's going to be so much destruction of bone if this falls apart that it's going to be very hard to reconstruct the site. I also worry about it doesn't have a very long track record. These products are fairly new. They haven't been around for 10, 15 years. So we'll see what happens. I have no reason to think that there's something wrong with them, but I just don't need them because I'm do fine with just using traditional wide body platform regular implants instead of the super wide. But many of my friends like them and they're big advocates. So let me show another case. This is again another molar implant case. So, whether to bury them, use a healing cap, what do you do when you use a healing cap, those kind of things. So prepare the site. You can see the osteotomy is not always in where you think it's going to end up, even though the implant's pretty much in the middle. I use a cover screw again to pack bone around it. And some authors suggest that there's no need for bone. It's going to be fine without bone. I place whatever bone, I use allograft, but I place bone material in there because there's no real loss. It's not something you charge the patient for or anything like that. You just pack some bone around it. I feel better when I do that, whether it's legitimate or not. But many authors think that it's fine without doing anything, and I'm sure it is. So what you're seeing is that's a healing cap, and it's a fairly wide healing cap. It's a 6.5 platform healing cap. I place the bone all the way up, and I pack it also, same as I do with my aesthetic zone implants and temporization. I pack it all the way up, all the way to the tissue, almost treating it like an aesthetic zone. Sometimes I can just close it and maybe put a little tissue glue, some Histocril around the area, and I'm fine, and it retains and everything's okay. I never flap to do this. It's just the suture sometimes will hug the healing cap well enough that you get a pretty good result. So other times what I'll do, if the tissue's too tight and it's not going anywhere, I'll actually put some collagen sponge on there and then place some Histocril on it, and that's about it. And so, sometimes I don't even suture it. I just let it stay passively. So this is the tissue. You can see what it does as time goes by. This is a week out, and this is about 4 weeks out. You can see it's healed in, and there's no issues, and everything is keratinized, and the tissue is nice. But I do follow the similar protocol that I do for immediate implants in the aesthetic zone. Is I like to pack the bone all the way to the tissue margin, not just to the bone crest. So in summary, there's only 2 rules that matter. Rule number 1 is case selection, and this is just as important for molar implants as aesthetic zone in the anterior implants. And rule number 2 is always follow rule number 1. So a few things to watch out for. High aesthetic expectation, it's always a red flag for me for any patient, whether the case is difficult clinically or not. High smile line and thin tissue and the other things we discussed in the aesthetic zone. Compromised buccal wall, of course. I prefer to do things flapless when I can. I do think it makes a difference. Palatal placement is critical. Again, this is for the aesthetic zone. And I do graft the gap. I do place grafting material in the gap. I think that I do end up with a better aesthetic result than when I don't. And finally, temporize if you can. I think it's a benefit to the patient. I think it can end up with a better aesthetic result. So when it's feasible, I do like to temporize, or my referral likes to temporize. I'd like to thank everyone for listening to my talk. It's always a pleasure to speak to the Dental XP community. I hope you enjoyed it, and I hope to hear from you soon. Take care. Bye-bye.